Now, we talked a lot about the pandemic that is there about diabetes, but I want you to focus on what's going on in the Africa region. It's interesting that when you look at our prevalences, it's as low as 4%, yet we're the ones who have the highest morbidity and mortality. So, where are we going wrong? I think majority of it is because up to 60% are undiagnosed. We're walking around minding our own business. People are not even aware that they're suffering from diabetes. So look at what happened when they looked at they went and got a population in India, about 113,000 individuals, because they wanted to talk about how serious this crisis is. And they found just because of picking people randomly, the prevalence of diabetes was 11.4%. But look at the prevalence of pre-diabetes, people we could potentially have reversed, 15.3%. But of the 11.4, only 3.6 were achieving, 36% were achieving basic glycemic control. But remember, a patient doesn't come with just one condition, isn't it? They have hypertension, they have cholesterol and all. So you find the numbers even go lower. So we have all this newer technology, we have the medication, but we don't seem to be getting it right. So it's time to step back, start working smart instead of hard. So this is the missing link, and I want you to focus on, if there's one slide you're going to focus on, it is this one. You come and a patient comes to see you. Now, anyone who manages patients in chronic care knows you really should not be seeing this patient monthly. There's no additional benefit. So you see the patient in January, and the next time they're coming to see you in April. In 3 months, so much can happen. If it's a woman, she can be pregnant. If it is a gentleman, anything could have happened. You have got an infection, you could have been admitted, but you never get to know what is going on. So what about if we introduce something called continuous, integrated, personalized diabetes management? What does this mean? That from the time that they are gone for the clinic visit, you suggest to them that we have apps where you can be able to input the data. How many of you have worked in government hospitals and patients come with a whole logbook of their glucose readings? Some of them are so proud because they're showing you sugars for the last 3 months. Do you actually have the time to look and interpret all those sugars? Realistically, you peruse through, isn't it? So what we're saying is, what if the patient inputs this into an app and you can be able to see the trends? And so like that, you can be able to get real-time data, and you don't have to constantly be called, my sugars went to 4, it went to 15, what do I do? Nutritionist. I get messages, I'm told it's been rejected, the patient cannot see the nutritionist. Yet the diagnosis there is diabetes or pre-diabetes. So one of the things I think we should be doing is inviting also insurance to understand why, because it's integrated management. We give medication, we prescribe diet, we prescribe exercise. So why are they not paying for one versus another? And then us as healthcare professionals, we get overwhelmed. I remember when I was working in Kenyatta, we used to see 80 patients. In Mama Lucy, we would see on one day 80 patients, and I'm there with 5 other clinical officers. If you ask me if I remember one single patient, I will not, because it felt like it was clearing and forwarding. So we really need to start to work smarter, the sugar levels. Then this helps to track what's going on, and you can see it can be able to tell you how has the patient been doing for the last 7 days, 14 days. Now remember, the more that they do, that also gives you an average of how the sugars are. And with that, you can be able to interpret how you're going to manage. So what is the utility of these interactive healthcare platforms? It's supporting you and ensuring you're giving adequate treatment to your patients. A patient is more likely to be compliant if they're seeing their progress. It's like having a report card when you were in primary school and you come and you show, oh my God, I've done so well. You see there's a reduction in diabetes distress by up to 19.3%. But there's a clincher here. The less you monitor, the less likely you are to see any changes in the blood glucose, in your A1C. So you have to literally encourage your patients that the more you log in, the more likely we're going to see changes. Now this one, I smiled when I was actually going through the data. Who's more likely to benefit from such, the apps, the tech? it's us seated in the room, meters, was 40 to 50-year-olds. But when they looked at who is more likely to achieve much success, if you give to someone who is on oral hypoglycemic agents, we don't anticipate much change. But what they found was it was less bulky, less cumbersome carrying the logbooks and just inputting. But for the insulin users, it was amazing, especially for type 1 diabetes. Why? There was one improved therapy adherence. So for the type 1, we usually recommend carb counting. And the problem is if they're not taught well and you end up adding doses of insulin, there's a risk of insulin stacking and them getting hypoglycemia. So this actually helps track and they can be able to figure out what is going on. The other thing that we look at is those people, especially when they have been struggling, because it's not for everyone that they're likely to accept this app.